Judy in MG Medical College, Aurangabad. The topic assigned to me for your lecture is diseases of esophagus. So this is a huge topic. It has got lots of entities in it, but I have tried to cover most of them in small sessions. So we'll go forward with it. Am I audible to everyone? Sir, am I audible?
Yeah.
So if you see the anatomy of the esophagus in just a small gist, it starts at the cricopharyngeal sphincter as the continuation of the hypopharynx. It pierces the diaphragm at T10 and it is divided into three basic parts, the cervical, the thoracic and the abdominal. It has got four constrictions, one at the cricopharyngeal sphincter, one at the crossing of aorta, and one at the crossing of the left bronchus, and at the cardiac sphincter. So this is the esophagus where you can see where it is joining with the pharynx. From there it is continuing down and coming over here it is entering the stomach, joining the stomach over here. This is the diaphragm where it pierces. Okay, now classification of disease of esophagus. Basically, there are 10 major classifications. So the first type, the first infection will be esophagitis. Second will be esophageal trauma. Third will be a hiatus hernia. Then we have got Plummer-Wilson syndrome, dysphagia lusoria, achalasia cardia, GERD, that is gastroesophageal reflux disease, Satsky's ring, globus hystericus, and corkscrew esophagus. Now, esophagitis is basically of 5 types: infectious, drug-induced, eosinophilic, reflux, and Barrett's. So we'll be first dealing with esophagitis. Now, eosinophilic esophagitis, it is a chronic allergic hypersensitivity reaction where there is inflammation and where eosinophils go into the esophagus in huge numbers and they cause an allergic reaction whenever the trigger food is ingested. So it usually involves the proximal and distal part of esophagus. It is usually due to foods which are not suitable to that particular person. It may be due to food, it may be due to substances in the environment like dust mites, pollen. The main symptoms with which this patient presents to us is dysphagia 1. Then he'll have a sort of choking sensation as if something is stuck in the esophagus. Then he will have fluid regurgitation, he may have vomiting, and he may have pain in the epigastrium. So the treatment for eosinophilic esophagitis is you have to know whatever is suiting your body. So that means you have to do lifestyle modifications. Like when some people, whenever they have something very dry, be it fermented food, that time they have that inflammatory reaction, that time they have eosinophilic esophagitis. So you have to identify what food is not suiting you and you have to stop having that food. So that is all about reflux eosinophilic esophagitis. The second part is reflux esophagitis, where again there is inflammation of the esophageal mucosa, but this is secondary to gastric esophageal reflux. So it is basically a disease of the lower esophageal sphincter, usually occurs in pregnancy, can occur in any trimester of pregnancy, and after pregnancy in ladies it resolves. Causes are again reflux of gastric acid into the esophagus. There may be some infections, there may be some drugs, it may be due to allergies. Treatment is again proton pump inhibitors and lifestyle modifications. Now, Barrett's esophagus it's a complication of GERD, that is gastroesophageal reflux disease. It's a precancerous condition. It involves the distal part of esophagus, where the normal stratified esophageal epithelium is converted to, now this is the normal esophagus and this is Barrett's esophagus. Now this stratified squamous epithelium is converted into intestinal columnar epithelium. Again, this is due to long-standing cases of reflux. You have to do an investigation in the form of barium swallow or an oscopy, that is esophagoscopy. Treatment is anti-reflux diseases. See, now this is Barrett's esophagus, where this entire mucosa is converted into the intestinal mucosa. So treatment is by anti-reflux diseases. There will be regular follow-up of by endoscopy, which you have to do to know whether that acid has caused dysplasia and malignancy in the lower part of the esophagus. And if there is a multifocal dysplasia, you will have to do a surgery in the form of either you'll have to remove that particular part so that it does not become a predominant site for malignancy. Now, coming to the second point, that is esophageal perforation. Now, causes will be intraluminal and extraluminal. So, intraluminal will be anything which is causing injury to the lumen of the esophagus from inside the esophagus. Extraluminal will be that which is causing injury from outside the esophagus. So, intraluminal will be either in the form of instrumental trauma during oscopy, during any other surgery which has been done for the stomach, or it can be any foreign body ingestion. Usually meat pieces, they get stuck over there. They cause some erosion. In lots of cases, there is a foreign body in the form of some safety pin which has entered the esophagus, or it can be anything. Coins stuck in the esophagus for a long standing duration, they will cause erosion on the sides. So caustic ingestion in the form of some ingestion of acid. It can be a case of CA esophagus. It can be due to barotrauma. Barotrauma, again, there is increased pressure changes which cause injury to the esophagus from inside, leading to esophageal perforation. Now, extraluminal causes will be, it can be any penetrating trauma in either road traffic accidents or in some mob fights. It can be a blunt trauma, again in the form of RTA, or it may be a surgical trauma. So if there is spontaneous rupture of the esophagus, it is known as Boerhaave syndrome. In macular stride, there is a lot of syndromes which are attached to esophageal perforation. So in macular striate, there is chest pain, there is vomiting, there is spontaneous emphysema. In cervical perforation, if the esophagus is perforating in the upper part, so patient will have cervical symptoms in the form of neck pain. There may be dysphonia because there is pressure over the larynx. It can be, there may be hoarseness of voice. Now, signs is there is tenderness over the sternocleidomastoid. There may be cervical subcutaneous emphysema. To treat esophageal perforation, you will have to do certain investigations in the form of X-ray neck. You will require X-ray chest. You will require an oscopy or an esophagogram. You will require a CT of the chest and abdomen. Treatment will be medical and surgical. Medical is you have to put the patients on OPO1, then you have to start IV fluids, that is 5% DNS or ringalactate, whatever parenteral nutrition you can give to maintain the patient's general condition is required. You will require a Ryle's tube ingestion. Surgical will be in the form of drainage of any emphysema which has occurred in the neck on the chest. So it will be, you will require thoracostomy. You will, whatever retrovisceral space has got air or fluid accumulation, that has to be drained. Then repair of the perforation has to be done. Complications will be in the form of mediastinitis or intrathoracic sepsis, or patient may ultimately go into shock. So that is all about esophageal perforation. Now, foreign body esophagus, very common entity in ENT practice. Symptoms, patient usually gives us a history of some foreign body ingestion. Usually it is a child who are taking in either coins, or at times safety pins are there, or at times any small plastic tube of either the lid of the pen or the lid of the sketch pen. Weird things people put just while they hold them in their mouth and then they take them into the esophagus. So usually patient will come to you with pain and discomfort. He will have dysphagia. He'll be a very conscious, alert patient, but very much worried. Usually they are small children whose parents come to us with a history of ingestion in 15 minutes or 1 hour. So they will be retching, they'll be vomiting, drooling of saliva, and ultimately some patients may have respiratory distress or epigastric pain. So on investigations, you will require an X-ray neck. Like in this, you can clearly see the X-ray where you can see the foreign body. It's a coin. Now to identify whether the foreign body is in the esophagus or in the bronchus, you do require a lateral view. In the lateral view, you can clearly see the air shadow of the trachea on one side and the foreign body lying in the esophagus. Now, this is the foreign body which you are seeing during the oscopy, where this foreign body is stuck inside the esophagus. So you have to remove it with the help of a oscopy. Okay, investigations, X-ray neck, X-ray chest and abdomen, CT MRI if available, if you suspect that there are multiple foreign bodies. Now, treatment will be in the form of emergency oscopy and removal under general anesthesia within 2 to 6 hours if the patient is having absolutely dysphagia. Or some patients have taken in batteries or sharp pointed objects. So for all such cases, it has to be done immediately. Okay, caustic ingestion, substances which have got very high pH value, they are corrosive in nature, they cause severe injury to the aerodigestive tract. So there we've got 3 stages of esophageal burns. It can be stage of acute necrosis, stage of granulations, and stage of stricture. If the pH is little bit mild, then patient will have only mild necrosis of the esophageal mucosa. So this is the first stage where there is minimal necrosis of the mucosa. In this is the same thing. Over here, you can see all the granulations which are formed. Now, this is the third stage where it's a clear-cut stricture formation. So patient will complain of burning pain. Patient will have excessive salivation. Patient will have respiratory distress, vomiting, epigastric pain, and retching. Now, investigation of choice again for this case will be radiological and endoscopic. So, radiological again, you can go for a barium swallow if the patient is tolerating it, or endoscopy if it is a third degree burn. That is, if it is a stage of stricture, doing an endoscopy is not at all advised because hypopharynx will also have strictures in it. So, for that, you have to plan and then you can only do a endoscopy. Now, treatment in this case is first of all, admit the patient in ICU and do an Ryle's tube insertion. You have to start the patient on IV fluids and IV antibiotics. If the esophageal perforation is there, you will require, because of the caustic ingestion, you will require a total esophagectomy with a gastrectomy. You can neutralize the caustic agent. If it is an alkali ingestion, you will require mild vinegar, lemon or orange juice. If it is an acid, you must start the patient on milk, eggs or antacids. Now, complications is strictures, stenosis of the antrum and pyelotus, and CA of esophagus and CA stomach. Okay, esophageal bleeding, very common thing. It is esophageal varices. They are enlarged veins which are present in the esophagus. Usually they develop when the blood flow to the liver is blocked by a clot or scar tissue. So basic cause is cirrhosis, that is excessive of, usually due to excessive of alcohol ingestion. So causes will be cirrhosis, hepatitis, alcohol liver disease, fatty liver disease, and bile duct disorders. Symptoms will be on vomiting large amounts of blood, frank blood or clots. Anything will be there. You will have stools which are black, tarry or bloody in nature. Investigation will be again an endoscopy. You have to identify the bleeding veins. You have to identify the enlarged veins and start the patient on medical line of treatment in the form of beta blockers. In severe cases, you will require to do a band ligation or you will require a transjugular intrahepatic portal systemic shunting, which is also known as STIPS. Okay, hiatus hernia. Again, two types. It is herniation of part of the stomach into the chest through the opening in the diaphragm. Now, causes are chronic coughing, lifting heavy objects, straining, and during the bowel movements. Types are two types, sliding type and paraesophageal type. So, sliding type is most common. Over here, this is the sliding type which you can see. This is the sliding. This is the normal thing where the diaphragm is there. You can see the esophagus, you can see the stomach. In the sliding type, this is the esophagus and this is the stomach. But this stomach sort of slides up through the diaphragm hole and it goes up into the mediastinum. So this is the most common type and this is the paraesophageal type which is known as rolling hernia. Investigation of choice is barium swallow, flexible oscopy and esophageal manometry. Manometry where you have to know what is the pressure, if there is increase of pressure which is causing formation of the hiatus hernia. So that has to be identified. Now, treatment of choice is again medical and surgical. Medical is PPI, that is proton pump inhibitors, H2 receptor blockers. We do require prokinetic drugs, anything which will reduce the pressure, anything which will cause modification of the lifestyle where the patient is not having to pick up heavy objects. Where he's having chronic cough, you have to treat that cough. If he's got a job as where he has to lift heavy objects after bending down, that has to be stopped. If he's got a case, if he's got a case of chronic constipation, that constipation has to be treated. Now, surgical treatment is in the form of fundoplication, that is Nissen's 360-degree method, usually done by surgeons, not in the range of ENT surgeons. Usually, we are not doing it. A gastropexy or a PG, that is a percutaneous endoscopic gastrectomy. Okay. Plummer-Wilson syndrome, these patients are very common to us. It is 4F. Fat fertile female of 40 who comes to you with history of decrease of appetite, history of food sticking or stuck inside the esophagus. It is as if she cannot take the food in. She has to take in lots of water to swallow that food. First instinct will be it is a Plummer-Wilson syndrome. Okay, so the triad is of dysphagia, post-cricoid web, and an iron deficiency anemia. Usually after 40, whenever there are hormonal changes, if the HB starts decreasing, these ladies will come to me. So the basic cause is iron deficiency 1, most common is iron deficiency and genetic predisposition. Incidence is common in females 40 to 70 years. 4F again, fat fertile female above 40. Now the pathology in this case will be there will be thinning of the mucosa because of iron deficiency. The intrinsic factors of blood are not produced, leading to submucous fibrosis, more common in ladies who are taking tobacco in any form, be it supari, be it tambaku, be it anything. In kheni also in some places, in some villages, tribal areas, they do take kheni. That is also causing all this problem. So there is mucosa which is there. There is degeneration of the muscles of the esophagus. So because of that, they become lax. The food is not able to go inside. It is sort of the density of the mucosa of the esophagus is lost. So because of that, you have this issue. Now, investigation of choice in this case is again barium swallow and upper GI scopy and gastric fluid analysis. You also have to do an hemogram to know what is the iron level of this patient, ferritin levels, basic iron levels. Treatment will be iron infusion in the form of either PCB, or you can start an iron injectable to the patient, or you can start with iron tablets, but tablets do take a lot of time. Then infusion of vitamins, again IV, whatever you all want to do, you all can give. It can be iron, it can be multivitamins, it can be iron maltose injectable once a week, you can give through IV. Oscopy, and if there is formation of a web, that web has to be removed under general anesthesia. It can be either dilated through a bogey or you can do a laser excision. So you can dilate the lumen by a bogey also. Now that is about Plummer-Wilson. We'll go to the next topic, dysphagia lusoria, very common short note which is there. Usually asked, there is dysphagia due to abnormal right subclavian artery, which is also known as a lusorian artery. Now this compresses the esophagus. Now, in this case, you will see where is the esophagus and where is the aberrant artery. This is the aberrant artery which is causing pressure over the esophagus. Now this is leading to dysphagia. It is usually a common congenital aortic root anomaly. Symptoms again, they come in the age of late ages, but still this patient, most of these patients are asymptomatic. 30 to 40% of these patients are asymptomatic. Patient has got dysphagia and dyspnea. Patient has retrosternal pain. Again, investigation. See, commonly esophagus, all investigations are the same for all usual diseases of the esophagus. It will be a barium swallow, it will be an endoscopy, because there is no other way to visualize whatever is there inside. So barium swallow, you will see indentation in the posterior wall near the aortic arch. You will require an arteriogram. You will again require a CT. Treatment will be reanastomosis of the aberrant right subclavian artery to the ascending aorta. So CVTS comes into role over here. Okay. Acladia carcia, common cause of motor dysphagia. Triad is of dysphagia, regurgitation of food and weight loss. There is high resting pressure, nearly 40 mm mercury in cardiac sphincter. And it is basically of two types, primary and secondary. Primary is due to idiopathic degeneration of the orbix plexus, and secondary or acquired is due to lifestyle. Now, in this case, it is caused by CA esophagus, Chagas disease, post-surgical or pleural mesothelioma. Very rare thing, but yes, it is there. Symptoms are dysphagia for both solids and liquids. There is chest pain which worsens with food. There is heartburn and there is weight loss. This is what you see on barium solo. We call it the bird beak appearance because there is absence of fundic air bubble and it is as if it is the beak of a bird. You see this thing? It is as if it's a bird's beak. So we call it a bird beak appearance. You can have an X-ray of the erect abdomen. Usually barium solo is the diagnosis. You'll require a USG. You can do a video fluoroscopy or a manometry studies. Treatment is Heller cardiotomy where you have to repair the motor dysphagia. Okay, it can be Heller's cardiomyotomy, it can be Heller's myotomy, or at times nowadays we are giving botulinum injections in the lower esophageal sphincter. Treatment again is treatment for anything can be a malignancy. Malignancy in the mid and lower esophagus. Now GERD, the most common thing which is there nowadays, that is gastroesophageal reflux disease. It is a hypomotility disorder of the esophagus in where there is abnormal reflux of gastric juice into the esophagus and laryngopharynx. Now, this is due to decrease in the lower esophageal sphincter. Causes are obesity, pregnancy, hernia, smoking, sedentary lifestyle, no exercise at all. Now, that is the basic concept for causing GERD. Drugs will be any bronchodilators, any dopaminergic drugs. So these will be responsible for causing GERD. Symptoms are in the form of heartburn. You will have regurgitation of food. You will have dysphagia. You have a patient is usually come to you, something is burning in the stomach. Something is burning in the stomach. Patient is having burning sensation in the neck. Patient will come to you with there is something burning inside. And whenever I have something, it aggravates, the pain will aggravate. Now, that is typical GERD symptom. Hoarseness of voice will there if there is lot of regurgitation into the larynx where the vocal cords are getting every time exposed because of food. The regurgitation is coming up through the esophagus and that acid while lying down is going into the larynx. So that will cause hoarseness of voice. Patient will have sore throat because erosion of the oral cavity, oropharyngeal mucosa. So patient will always have sore throat. Multiple ulcerative, small, non-significant ulcers in the oropharynx, but patient will say there is a burning sensation. So basically, it is of three types: physiological, pathological, and secondary. So physiological, it has got no underlying predisposing factor. Pathologically, if it is associated with complications, and secondary, if there is some underlying condition in the form of gastric outlet obstruction. Now, management is basically it is PPI. First of all, it is lifestyle modification and PPI. So investigation will be again oscopy, where you will see that the entire mucosa seems to be eroded of the esophagus. It has got small ulcerative lesions because of excesses of gastric reflux. Lots of tests which we can do: esophageal manometry, which is the gold standard. Then we've got Bernstein's test, which is the acid perfusion test, and barium solo as usual. So treatment will be lifestyle modification. There will be antacids, PPIs. Now, surgery for GERD is very rarely. If the patient has got only GERD, then very rarely do you require surgery. Usually by lifestyle modifications, some exercises, some regular use of antacids or lactobacillus at times, patient gives us a very good response. You will do surgery if there is a lot of complication, like patient is having varices because of that, patient is having strictures because of that, or he is having aspiration pneumonia or some stenosis in the glottis. So in such cases where GERD is in a very late stage, that time you may require some surgery in the form of Nissen's fundoplication or minimally invasive esophagotomy. Now, Satski ring, it is narrowing at the lower part of esophagus due to the mucosa which is forming a web-like lesion, usually seen in young people who have got some injuries, who may have had some traumas or hiatus hernia or strictures. Now in this, you can see this is the ring which you are seeing. See, here is the hiatus hernia and here is the ring which is formed. So this is what you see on barium solo. So symptoms will be episodic dysphagia. Patient, like, it is as if a bolus of food is completely obstructing the esophagus. Patient will have severe chest pain. At times, patient consider it to be sort of a disease. Patient is having a MI, that is such bad chest pain patient has. And it can produce a swallowing syncope also. In this diagram, you will see this web-like lesion which is forming over here. See this web which is coming over there. So investigation again a base solo, and you can do a bogey dilatation or a balloon dilatation in this case. Now globus hystericus, usually a psychological disease, functional disorder. Patient complains as if there is a lump which is there in his neck during meals, but there is no dysphagia during meals. That is the basic thing. During meals, there is no dysphagia at all. So if you examine the digestive tract, everything seems to be normal. You may do a barium swallow, you may do a scopy, everything seems to be normal. Usually oral cavity, oropharyngeal examination, everything is normal. Basic causes anxiety. So only in this case, you have to reassure the patient that nothing is wrong. There is no pathology inside. You have to only counsel the patient, and if need be, you can refer the patient to a psychiatrist. Okay, the last one is corkscrew esophagus. It is also known as the nutcracker esophagus. It is also known as hypertensive peristalsis. Now, this is as if there is a screw. See now, this is as if it's a screw-like thing on barium solo. When you rotate the screw, the rings which you see, these are the rings which are seen inside the esophagus. So it is a motility disorder in which there is incoordination of peristalsis. There is dysphagia for both solids and liquids. Basic cause again is GERD. Basic cause is basically GERD. And treatment is again lifestyle modification. You cannot do much for this. No surgery as such is required in this case. Okay, that is all. We finish off with this lecture. Any questions? Any questions as such? Can you hear me? Starting slides again, sir. Shall I start again? It will become too much. I think that it was just a second. Okay, so the basic first, some few slides I'll take. The first slide was where we took the anatomy of the esophagus, where it starts at the cricopharyngeal sphincter. It is the continuation of the hypopharynx. Now, as you know, pharynx is divided into three parts: nasopharynx, oropharynx, and hypopharynx or laryngopharynx. Now, esophagus is this continuation of hypopharynx. Now, it starts at the cricopharyngeal sphincter. It pierces the diaphragm at T10. See now, this is the esophagus. This is the pharynx. Now, this is the junction of the esophagus with the pharynx. This is the esophagus which is coming down. It has got basically four constrictions, one at the cricopharyngeal sphincter, one at the crossing of aorta, one at the crossing of the bronchus. Now, this is the part where you are seeing the bronchus is crossing. Now, this is the part where esophagus is crossed by the arch of aorta and the cardiac sphincter. This is the hiatus, esophageal hiatus in the diaphragm, where the esophagus is perforating the diaphragm and going down and continuing as a stomach. So parts of the esophagus are cervical, thoracic, and this is the part which is abdomen. Okay, now classification is again 10 basic types. Esophagitis, esophageal trauma, hiatus hernia, Lamar-Wilson syndrome, dysphagia lusoria, eclasia cardia, GERD, Satsky's ring, globus hystericus, and corkscrew esophagus. Is it all right now? Sufficient for me to stop? Yes.
Ma'am,
Slides again. One is asking me to repeat the foreign body esophagus. Just a sec. It has the slideshow has stopped working. Share wherever it is. I have to see. But they're still on. The questions. Let me see which are the questions. हाँ नहीं share तो करना ही है, but I have to see whatever questions have come. Chat box में.
मैम राइट बॉटम में चैट बॉक्स है मैम, उस पे आप एक बार क्लिक कर लीजिए।
हाँ. What is the management of button battery ingestion by child? First of all, remove the foreign body. Can you all hear me?
Yeah, ma'am, you are audible clearly.
What is the management of button battery ingestion? First of all, you have to remove that battery. First of all, once the battery is removed, put the patient on IV fluids. No, it is a acid disease. So to neutralize it, you will require some alkali. Start the patient on IV fluids. He has to be nil by mouth. Later on, you can start the patient on cold milk. It does help a lot at times. Okay. Second question. Chat box. Rigidoscopy, how do you want me to explain rigidoscopy? You've got something like a rigidoscope. You have to take the patient under general anesthesia. You have to insert the rigidoscope and you have to see if there is a foreign body, you have to remove it. Eosinophilic esophagitis again. Okay. I think only one question is left of eosinophilic esophagitis. That I'll start again. ये लगाना फिर fourth slide. PPT पे करना पड़ेगा. So eosinophilic, can you all see this? Eosinophilic esophagitis?
Yes, ma'am.
Ah, so it is a chronic allergic hypersensitivity reaction in where there is inflammation due to migration of eosinophils in the esophagus. Now, this is usually due to any food which has been ingested and which is causing an allergic reaction. So it is an allergic reaction which is precipitated when a trigger food is ingested. It usually involves the proximal part and the distal part of the esophagus. It is usually due to ingestion of food, or it may be due to substances in the environment like dust mites or pollen. Patient will come to us with dysphagia and a sensation of food stuck. Now, this is the eosinophils which you can see. So patient will come to us with a history of dysphagia and a sensation of food impacted into the esophagus. He'll have a choking sensation where he says that the food is stuck inside my esophagus, or the food tract is having severe pressure, he will complain. There will be regurgitation of fluid. At times there may be vomiting or there may be pain in the epigastrium. So in this case, you have to identify whatever food is causing that reaction, because at times you do realize, okay, I had this food, so this time I had this symptom. Next time again, whenever I have that food, I'm again having that symptom. So the patient himself has to identify, or he'll tell the doctor that whenever I have this food, I have this problem. So you have to do modification of your lifestyle. That is all about eosinophilic esophagitis. I think we can stop now. People are asking for this PDF. I think the NBEMS will do that. Have written, please share with us this presentation. We mailed